Happy Monday, folks. This is the CDH Dad and
the CDH Warrior.
And we'd like to welcome you back to another episode of Mondays on Mondays. As you can see, it's a bright and beautiful Monday. We apologize for the background noise. We have a neighbor that's mowing their grass, but we really prefer to do this outside. And just again, the general disclaimer information. My son and I are neither one medical professionals or in social work, therapy, any of the medical professions, but my son was a CDH, congenital diaphragmatic hernia, at birth, and then my daughter at about 18 months was diagnosed with aplastic anemia and ended up having to go through a stem cell transplant and the issues with that. So as a family, we have a very in-depth knowledge of having to deal with special needs children, the issues involved both from the kids' standpoint and from the parents. And from that, we would like to just welcome you once again. And in the video, you will see an email address, Mondays on Monday
4@gmail.com.
So that will show up a little bit later. So if you have any comments or questions, please address those in that direction. So thank you very much for joining us again.
With that, let's roll the title.
Okay, and as we said, welcome back once again to Mondays on Mondays. The topic that we want to kind of go over today is the muscular system and developmental issues and problems that do show up. And part of the discussion my son and I have had is the differences between my two children and the issues they've had. Do you want to go through about the CDH, congenital diaphragmatic hernia? You can tell it from your standpoint, but
Yeah.
you don't necessarily remember what happened before you were a few years old. But
No, but
I can throw in my comments there.
a lot of times what I see with CDH is it's children that they've been in a hospital bed for, you're considering 3 months or more minimum. So they're not able to move. They're not able to really do the typical
Developmental activities.
development.
Yeah.
So when they get out of the hospital bed, they basically have no muscle tone. It's not that the muscle doesn't function, it's just that they don't have the tone to actually do anything. So that has to be slowly worked back with physical therapy and even some occupational therapy.
Right.
Because you're considering that they were tube fed by an NG or a G button.
Right.
So they didn't get things like the self-swallow reflex or any of the facial muscle development that a normal, let's say, 4-month-old would have.
Right, and it's one of those things, we don't tend to think about how much activity a baby or a child goes through in their normal day-to-day life. And if you've got a CDH child, typically you're going to go through, the protocol is to stabilize the child, take care of any respiratory issues, make sure that the feeding is taken care of, those type of things. And then, if necessary, do the surgery, and then go through the recovery period after that. And it's very critical at that stage to work very closely, not only with the medical professionals, the doctors and the nurses involved, but also to get the hospital therapy staff involved in basic activities. As you mentioned, suck swallow is a difficult situation. Now, in our case, we go back almost 3 decades ago, and this is when some of the protocols were just being developed. So therapy was just beginning to come into the forefront. I think now that there's quite a bit more in terms of therapists understanding the need to start working on some of these things as quickly as possible.
Therapy is more of a standard protocol as opposed to just being an afterthought.
Right, and that's where it's critical to work with your healthcare professionals in the hospital and then once you get home, because your baby is going to be at a deficit if they were a CDH child. So at that point, you're going to have to work with therapy and professionals. Start working with early childhood intervention, whatever programs you have within your state capabilities that can provide some resources that can evaluate your child's deficits and help you work on some of those practices and things that you can do with your child to help them quickly get back up to speed. Generally within 6 months to a year, they can pretty much be back on track with most of the milestones that you would expect with children. But they're going to be at a deficit because they're weeks or months basically at bed rest. Many times they're on hypertension drugs, which will limit activity. Many times, particularly if the child on ECMO, they will keep them heavily sedated so that there's no movement, they're not grabbing at the tubes and those type of things.
There's sedation, there's also a lot of times they're on weapons.
Right.
Whether it be, heparin or something like that.
Right. There are things where the medical staff wants to limit the activity.
Yeah.
And that causes some difficulties. So part of this is, even if your child is sedated, work with your therapist and your professionals on things that, just moving the arms and the legs. Even though the child's not necessarily able to move them on their own, go through and try and move the muscles, move the tendons, keep things kind of loosened up a little bit that will make it easier down the road. And part of the discussion that my son and I were having about this is that we've seen it from 2 aspects. In his case, we were dealing with right after birth and the sedation, and that went on for over a month, because it was really about 5 to 6 weeks before you were able to really get out of bed and we were able to hold you and do typical, some movement. So there were the delays there. But then also from the aspect of, with my daughter and the aplastic anemia, just to give you a background, aplastic anemia is basically her bone marrow had shut down. And she was diagnosed at about 18 months old. So up until that point, she was a typical toddler. The basic movements, walking, talking, doing all the basic activities. Now, once she was diagnosed on a Sunday, and that was a Sunday afternoon, and by that evening we were in the hospital, and she was beginning diagnosis and treatment immediately, because her bone marrow was at the point where she did not have the platelets to sufficiently be able to survive without intervention. So this was transfusions and a lot of those type activities. So we rapidly went from an active toddler to a bedridden child. And to give you some of the background in terms of what's required in the treatment for aplastic anemia, is basically she had to go through a bone marrow transplant or a stem cell transplant. In her case, we were able to find a donor that was the umbilical cord from a child that had been born, and the umbilical cord had been donated to a bank, and it was a 5 out of 6 HLA match. So we were able to utilize those in her treatment. But as part of that treatment means there are a week and a half to 2 weeks of heavy drug treatment.
Chemotherapy.
Well, Cytoxin and Atgam, which are very heavy doses of a lot of times what's used in some chemo treatments for cancer patients. So that puts a heavy toll on a child to have to endure those. So they really lose their activity levels. And then you're going through total body irradiation. So you've got a child that is now gone. In our case, she was diagnosed in February. The bone marrow transplant took place the 5th of May. So February, March, April, May. So 3 months she had gone from typical activity to basically non-activity.
Yeah.
Non-active, non-movement. So a very rapid decline in her physical capabilities. And then we had to go through letting the bone marrow engraft. And then we had
20 days, another full month.
Almost another full month.
I don't remember the exact estimate. But
it was almost 2 months from the time that she was given the stem cells until they were engrafted and she was able to be released from the hospital. And we had a couple of weeks where we were in a step-down unit, which was basically an apartment at the hospital where we could be with her outside of the hospital general setting, but general activities. So by the time we brought her home, just a few months, this is, February, March, April, May, 5 to 6 months, at that point, she wasn't able to walk, she wasn't able to do normal activities. She was still having to be fed through hyperalimentation. A lot of those things going on, still having to have blood draws, a lot of things even at home. So at that point, we were fortunate that we were familiar with having to use therapists from my son's treatment, and immediately contacted the early intervention, who we became very close friends with, and also with the therapist, to go through and start implementing immediately what therapies we could to get her back into normal activities. And this is one of having to learn to walk again, she was just beginning to get on a tricycle and do some of those activities. So trying to go through some of that. So what was 5 or 6 months of treatment meant that now we had 6 months to a year of therapy involved after that to try and get back to normal activity. Now, the other side point of this is,
can I jump in?
Okay.
When you're talking about the 5 to 6 months, that's not 5 to 6 months to get back to where they should be at the 6 month mark. That's 5 to 6 months to get back to where they were 6 months ago.
Right.
Where they should have been 6 months ago.
Right.
I wanted to clarify that because the way that sounded, it's 5 to 6 months and they're back to where they should have been at the age they are 6 months later. And
Right.
no, that's just to get back to where they were supposed to be 6 months before.
Right. Get back to a year and a half, and by this time she's two and a half years old.
Yeah.
So we've got that deficit. The other is, not only was it a matter of the success of the treatment, there were a lot of complications, but she had a condition called graft versus host disease. and I won't go into the details there, but this side effect of the treatment basically, whenever there is a transplant of a foreign body into your body, typically what happens if someone has a kidney transplant or something like that is your bone marrow, your blood system, will look at that organ, whether it's a kidney, liver, lungs, whatever it is, and says, wait a minute, that doesn't have the same DNA matchup of us, so it's a foreign body. So the body's natural inclination is to attack that. It happens quite often. In the case of a bone marrow transplant, your blood system is now looking at your body and it says, wait a minute, none of this is part of us.
Yeah.
So it may start attacking, and it can start attacking major organs. In my daughter's case, it started attacking the skin, which is actually an organ, large organ in your body, and there are issues there. So
your skin is actually considered the largest organ in your body.
Right.
Technically, it's on the outside, but it is considered the largest organ.
Right. So in that case, what happened is the skin had lesions, problems, weeping, tightening, those things, which meant that the movement was not easy, it was difficult. There was pain involved in that.
Didn't it start to blister as well? If I recall correctly,
it would,
her skin just start to blister?
Her skin would actually peel and weep. And that was the concern for any infections, those type of things. So there were a lot of issues there. So you've got the side effects that come into play that you've also got to deal with, but you still have to work on how do you work on the development and those things. And that's where it helps to get involved with physical therapist, occupational therapist, speech therapist. And we always think of speech therapist of, learning to talk. And we were trying to get her to get back to where she could talk and communicate. But the other aspect is also eating disorders and problems there. So look at all of the options that you have within the therapy world, how you can utilize those to help your child, because the sooner you can get them back to normal, the better this helps in terms of the physical and psychological and the mental aspects of the health of that child.
Yeah.
So that's kind of what we wanted to talk about today, is just kind of, the muscular system. We think of needing, occupational therapy and those physical therapy, in particular in geriatrics. But in pediatrics, it's a whole different world, and you need to find...
I'll put it a different way.
Okay.
The way I see a lot of people describe physical therapy is it's catastrophe therapy. It's basically you've gone from, for example, somebody had a car accident or is severely burned or something like that, and having to relearn how to function. Or in the case of my mother, from where she had the stroke and had to relearn everything.
Yeah.
But that's the way we see it. We don't necessarily think of a toddler or an infant going through physical therapy because we don't see all the movement that goes on with that.
Right, and part of what you have to deal with when you're looking for a therapist to help you with this is you've got a lot of pediatric therapists, and they are accustomed to dealing with children with neuromuscular disorders. A lot of the childhood defects and items that will be a long-term issue that you've got to work on and getting through those milestones. In this case, you've got to get someone who can look at, a very rapid, as we said, 6 months to a year, probably no more than 2 years, to get this child up and back to a normal functioning situation. So this is where you need to work very closely with your doctors, your medical staff, early intervention, and the therapist to see what you can do to help. So is there anything further that we have that you think we need to address?
Not necessarily, because I was thinking, okay, we went from the CDH perspective and the aplastic anemia perspective, going from a child that has started out with no function, as well as going from a child that had almost complete function to no function.
Normal function to limited function and then back again.
Yeah.
So these are the type of things that we want to be able to bring up in this discussion. We appreciate you joining us once again, and thank you for joining us for Mondays on Mondays.
And I'll try and go more in depth on Thursday on the CDH side of stuff with the muscular system.
Okay.
So stay tuned for that. For the CDH Warrior and
The CDH Dad, thank you very much.
have a great day.